we want to start the stream. Okay, I think I always started off the same way. Like, so like, unsure and so incredibly, like, what's the word I'm looking for? When you're not confident. Unconfident? Is it unconfident? Unconfident. Lack of confidence.
I don't think unconfident is a word.
How do you say that, like, I am not confident? Unconfident. I'm uncomfortable.
There's a word there. There's a word there that we're forgetting.
I need help. But I am very confident now. I need to, like, learn how to, like, start. How do you start?
Good thing no one's on yet,
Google Live. Right, exactly. How do you start a Google Live other than just saying, I think I'm doing it right? And this is what, our third or fourth one? Fifth?
Fourth, maybe?
Fourth. We're going to go with our ninth time doing this. And I'm really excited. So welcome, everybody, to the Medicare Cafe pre-chat, where Carrie and I just jump on a little bit early to kind of talk about things that is going on in the industry, answer any questions that you have. As always, we are going to be watching two methods of communication with us. One is utilizing our text line. It's there at the bottom of your screen. The other way, and that's, again, you're texting Medicare Cafe directly, which is really cool. The other thing is to, again, just comment on the video. We'll see those coming in live as well. So one thing I wanted to discuss, since you guys aren't having any questions, no questions yet, one thing I did want to ask Carrie was something she brought to me. I said it was a week ago. It may have been like 5 weeks ago.
I think it was.
But there was something really interesting that you kind of stumbled across, and that was Medicare.gov and utilizing MyMedicare.gov, that new enrollees are actually getting that done for them?
Supposedly. I don't know if it's getting done for them.
Is this mine?
Yes,
or did I just jack your coffee?
Nope, that's yours, not mine.
Okay.
Well, I think we were talking about My Medicare accounts, and, you know, some people assist their clients in setting that up. And I read something
on the internet.
It was a CMS document, PDF or whatever, with the little, like, it was legit. Mm-hmm. It said that for new 65-year-olds, that CMS is sending them a letter that with a username and password for a My Medicare account. And both, I think, kind of a cool thing, but also kind of, like, terrifying. Cool, because it is really helpful for the agent to have that information that's found on the MyMedicare.gov account. Good for a client to be more invested and more aware of what's going on in their healthcare. But, like, terrifying because, I mean, like, the post office, I'm not going to say talk crap on the post office, but, like, maybe they're not always the most efficient. They lose a lot of stuff. Mail gets sent to the wrong place a lot of times. There's a lot of information that could get out about an individual if the wrong person gets a hold of that letter. Well, and I'm hoping, like, okay, if it has a username and password, that there's still, like, another, okay, but enter your Social Security number in, too, to make sure it's you, or enter your Medicare number in. I don't know. I haven't had any clients say that they've gotten it. I don't think I've maybe asked all of them. I just try to ask when I remember. But if any of you have ever heard of your clients or seen one of these letters, let us know, because I want to see what it looks like or if they're actually doing it. I would also, like, how many of your clients are utilizing My Medicare? I don't personally know. No, I can think of one. One. I know of one that has talked about how they have a My Medicare account and have looked at their claims. Okay. More might be. But they're just not. They're not sharing that with me. But I feel like they would. I'm like, you're their Medicare expert. You're their Medicare guru. Surely they would tell you, like, hey, I'm utilizing this. This is a tool that I'm using, so on and so forth. What do you hear? I don't hear anything. Yeah. I don't hear anything about people utilizing it. I know, like, on Medicare Center, they have the blue button capability to where you click the blue button and it automatically uploads. If they have a MyMedicare.gov account, it uploads all those medications for them. But I've not heard of a lot of people utilizing that even. I feel like for me, now I obviously am in the health insurance world. Right. But, like, I would get on there if I was somebody that was, like, sick and had a lot of claims. Sure. I would probably look at my claims on there. I'll tell you what, but I have insurance, and especially, like, whenever I was going to the doctor all the time, when I was pregnant, of course, doing the whole delivery debacle. Did you never look? I never looked. Never looked? I have an entire thing. I have an app. I have a portal. They email me. Like, I currently now get emails like, hey, we just processed a claim for Kate, or whatever the case may be. I never look. Never look. I just assume that they're doing it correctly and go to sleep at night knowing that I will never know. I think I said this last time maybe, my first job out of college was at a medical billing office.
Mm-hmm.
And I saw on a day-to-day basis how wrong the claims were.
Oof.
And so I think maybe that's why I do it.
That's probably a good idea.
Or some people would call in and just be like, hey, if I give you X amount, will you count this as paid in full? And the provider I worked for would be like, mm-hmm. So I'm not saying that that's what you can do.
What, like, the underbelly of the billing when it comes to Medicare?
And I just worked in DME.
Yeah.
So none of these bills were, like, huge.
Yeah.
I mean, not much medical equipment. These were, like, a lot of, like, braces and, like, crutches and stuff like that. But I was so surprised at how many insurance carriers would just write it off.
Interesting.
So ask.
Just
be an
ask.
advocate for yourself. Don't just get a bill and pay
And for
it.
your clients. Be an advocate.
Yes.
I love that. All right, guys, so welcome. Again, it's now the top of the hour, so I do want to welcome everybody to the Medicare Cafe. Hopefully you guys are caffeinated. You're excited about your journey here today. We'd love to hear how everybody is doing. So again, guys, if you do have any questions, comments, concerns, threats, or promises, we do have that text line at the bottom of the page that does text Carrie and I directly. It is the Medicare Cafe text line. Carrie will be reading your text messages as well. You can go ahead and comment on the page as well. Today, maybe you saw our Facebook page today, we are going to be talking specifically about things that are like difficult to talk to clients about. And not difficult because it's like an uncomfortable conversation.
Just
more
hard
difficult,
to understand,
it's
maybe?
More difficult to understand.
Just complex topics, maybe.
So that's a great way. It's almost like you know what you're doing here. So first and foremost, what I want to talk about is really setting the precedence of like, your clients don't need to know everything. Carrie and I talk about this a lot too, where like, hey, your clients don't need a full Medicare 101 conversation. Like they don't need a 2-hour explanation of what Medicare is, but there are certain things that do need to be explained. And we're going to go through each of these a little bit more in depth and talk about like what and how we describe these to each client. But we're going to go over Part D coverage levels. Again, I worked in insurance for at least like 3 years before I genuinely understood how any of that worked. Yeah. Enrollment periods, Medicare Supplement versus Medicare Advantage, and then also Plan G versus Plan N. So let's start into Part D. I like to say specifically, anytime I do Medicare 101, it's one of my go-to phrases.
I was going to say, what? I could hear you saying this when I saw these slides.
It's unpredictable. I am a creature of habit. No. But it's 100% like, it's the government. It doesn't make sense. And I'm sorry if that's maybe not the right thing to say on a publicized forum, but 1 + 1, when it comes to anything Medicare, does not equal 2. 1 + 1 = fish.
Right. And it's a great way to say it.
None of it makes sense. And the math that when it comes to calculating Medicare Part D, the math doesn't make sense. And I'll kind of go through that here in a little bit. But it is extremely important for clients to understand the Part D levels.
Absolutely.
Because their coverage and how much they pay for their prescriptions will change throughout the year.
I think that's the biggest thing.
Exactly. And they just need to understand why and know that the expectations and when it's going to change for them.
I feel like whenever I present a drug plan, the first thing I say is, this is an estimate and this is your average monthly, but most likely you will not pay the same amount per month for the year.
Right.
And even just like right off the bat. So like,
just set the right expectation. And so honestly, for the majority of it, that's enough to explain to a client.
Right.
There is kind of a level of, again, kind of explaining why your coverages, why your plan or your copays may look different throughout the year. And explaining that you could do that primarily using Medicare Center and pulling up a Medicare Center. You can do a monthly breakdown and say, okay, so in October, your $10 a month copay is actually going to jump up to about a $70 copay versus or $70 co-insurance versus copay.
And here's why.
And here's why. So here is, again, I usually, whenever Sadie and we do our Medicare 101s, we usually break this down into doing a part by part, a step-by-step explanation of Medicare Part D. I don't have that luxury of doing this in this platform, but this is how, again, a working example that I have of doing a Medicare Part D and kind of talking through the limits. So really quick, what I do is, again, you kind of write down and say, okay, so you as the insurance agent, let's just say a prescription drug cost $20.
Mm-hmm.
That means you pay $5 because your plan says, okay, you're going to pay a $5 copay for this medication. The insurance carrier is going to pay the remainder $15. That's how you get your $20 prescription. You're going to pay your $5 copay, and the insurance payer is going to pay their $15 up until you hit this initial coverage limit, which is that $4,430 for 2022. After you hit that coverage limit, you're into something called the donut hole.
Mm-hmm.
The donut hole is not some...
I feel like that phrase is going away a little bit.
It is? Okay, Art, do people are like less familiar with the donut hole?
I think when I ask, they're like, no, what's the donut hole?
It sounds so delicious, and it's so not. It's so not delicious. But so again, that's good to know that a lot of people really. Do you feel like that's changing? That a lot of people did hear the term donut hole before, and now they don't.
Yes, I think it's like my 70+ clients still call it the donut hole, but the newer 65-year-olds, they haven't heard about it yet.
I wonder if it's because, like, remember with the whole ACA thing, they kept talking about how in 2020 the donut hole
was going away, completely misleading.
That didn't happen.
Yeah.
Good thing, another explain to your clients.
Right.
So once you hit that donut hole, again, I could spend a lot more time going into this. We do have a full video talking about this entire presentation on how to give it to a client. I think this goes into a little bit more detail than what your clients need to hear, but just for the sake of presentation. So once you hit that initial coverage limit, you end up in the donut hole, aka the coverage gap. Womp, womp, womp. And you do that until you hit your true out-of-pocket of just over $7,000. Now, this is where 1 + 1 equals fish.
The numbers do not match.
The numbers do not match. You look at this and say, well, that's not a huge deal. It's only a difference of about $2,600. And we say, screw that $2,600 because we're fish. And we say, okay, so at this point, what Medicare does is only look at what you paid in. So they only look at that $5 copay you pay that entire time. They completely ignore the $15 copay that pay that entire time. So let's just say in order to reach this, just under $4,500, you paid $1,000 of that. Well, they're now saying that you have to go and pay that $6,050 difference between what you paid into and the true up during that coverage gap. Then we say, well, that's actually not true either because that wouldn't be fair. And then that's when we talk about the 75% brand names and the 75% generic portion of Medicare Part D, talking about what that coverage looks like in the donut hole. So what I always say is, okay, this should still be clear as mud. None of that makes sense. All I'm trying to show you is that this is, according to the Medicare Center, this is when your prescriptions are going to change costs. This is when things are going to look a little bit different. If you have any more questions, ask me. Don't try to figure it out on your own.
Right.
Call my office instead.
I feel like I've only gone that in depth with less than 10 clients.
And
they don't want to know that much.
So much.
That's why they have us to help them.
And you have Medicare Center to literally say you're going to go in the donut hole in October, November. That's when you're going to pay this much money. In October, when you go fill your prescriptions, it's going to look different.
Right, it's going to look different.
Yeah, and it might be even worth, one thing you could do is if you have a client that you meet with during AEP and you see that they're going to go in the donut hole at some time, it may be worth a call from your office to say, hey, next time you fill your prescriptions, it may look a little different. Just be aware of that.
One of the quick ways I feel like I describe that is, I'll say certain drugs are subject to the deductible. So during that first initial deductible phase, you're going to be paying 100% of the cost of that drug. And then once you enter the initial phase, you're going to pay a small amount, and the insurance carrier is going to pay the bulk of the amount of that drug. And then once you reach a certain threshold, the insurance carrier is going to put a little bit more weight on you, less on them, and that's when you're in the coverage gap, and then you're going to hit the catastrophic coverage, and then they're going to cap you at X amount per copay.
That's way more awesome. I mean, just keeping numbers completely out of it. Just
they don't need
it
to know
super
those
simple.
numbers.
They just need to know that it's potentially your costs are going to change throughout the year, and here's why.
Yep.
Well done. Well done. The next thing that can be a little bit confusing for clients to understand whenever you're in the enrollment process is actually going to be enrollment itself. Why is it difficult? Well, mainly because 1 + 1 equals fish again. It's crazy how different Medicare supplements versus PDPs and MA plans are.
Right.
They both one has a 6-month period, the other one has a 7-month period. So it gets really confusing, and then they overlap, but not completely.
And I think it's, if you're on the original Medicare route, it's more confusing for you because you have the supplement functioning on its own enrollment window, at least in Missouri, when you can change that. And then you have your PDP functioning on a different time period where most people just expect, okay, every fall we're going to review it this time. I'm like, well, no, I might be reaching out to you in February when your anniversary period is.
So how do you explain that? If you're talking to somebody and you're talking about like their med sup, how do you explain like, okay, we need to review your med sup this time of year, but we need to review your Part D this time of year? How do you have that conversation without them being like, but it's all my insurance. Why is this confusing?
In Missouri, I feel like we're lucky because we have the anniversary rule. And so I typically just say, when we're applying, if this is effective in June, so just know every June you're probably going to get a letter from your insurance carrier telling you that your supplement it might have a rate increase. And then I always say on the back end, what me and my assistant do 30 days prior to that, we proactively run all of our June anniversaries. And I said, hopefully I reach out to you before you get that letter, letting you know if there is something possibly.
So that's a really
cheaper.
Great question. So you do for your med sup clients, you do shop for them annually.
That's one of the main roles of my assistant.
Okay. So that's something, again, like I know we have states like California, Nevada, Idaho, Illinois, that do either a variation of birthday rules or Missouri anniversary. Missouri's weird. This is the only one that goes by anniversary date. The rest of them go by birthday. Yeah. So we, like, again, a lot of times when we talk to agents about that, we say, be aware of it. Talk to your clients at the expectations that they may be having a rate increase. We always tell them, like, be very cautious to promise your clients you're always going to keep them on the lowest cost plan.
Well, and that's what I don't say that we'll switch every year. I'll say you most likely will be on this for a few years. But just know on the back end, like, we're constantly, basically I say that just so they know we're looking out for them.
So even if like they have a rate increase and maybe
we don't
another
even reach
plan,
out to them every year.
Really interesting.
Mm-hmm.
Okay,
we just do it on the back end.
I like that. So that they know, like, oh, if there was I said words there.
That.
If there was a better option, then like I know Carrie and her team's gonna reach out to me about it.
Yeah.
Yeah, I like that little confidence booster for them. Yeah. So how do you, when you talk to a client, because the med sup open enrollment period, the initial open enrollment is 7 months, 3 months before Medicare supplement is the month of
60 days.
Yeah, for open enrollment.
Oh, open enrollment.
Open enrollment, it is 6 months. Part D is 7 months, but it's the 3 months before, month of, 3 months after. So there's 2 months where those don't overlap. How many times have your clients run into they were in open enrollment for their med sup but couldn't get a Part D because they waited too long?
I personally have never experienced that.
That's good. I was like, how do you, I guess you don't really have to describe that with your clients too much because they enroll for them at the same time, usually before they're 65.
Right, because that way, I mean, most of the time I feel like if you're leaving one plan and you don't enroll in both the med sup and the Part D, I mean, then you're going to have a gap in drug coverage.
But do your clients understand that? I think that's the big thing. It's like, because like me looking at it, it doesn't make sense that the med sup is 6 months. The Part D is the month and 3 months after, so only 4 months from that perspective. So your clients don't really run into that as much?
No, and I think maybe my tactic of always getting in front of them way before, I'm educating them before, and we just like sign up for both at the same time. But, I mean, you can't always get to everybody that early.
Well, sure. And I know, unfortunately, a lot of people out there are like me, and they put it off. I am a what's it called? Procrastinator. I'm a procrastinator. So I can see someone like me, if I wasn't educated, to be like, oh, well, I'll just sign up for that Part D the same time I sign up for my med sup, and I have until June, so I'll just do it then. But I guess if you're talking about legitimately like how you're receiving health care, people may be less laissez-faire about it.
I think so. That's what I see.
So do you do in the enrollment process, when you talk about enrollment, do you do that in your Medicare 101, or do you even address the fact that it may look different?
I feel like I talk about enrollment periods, like, are we talking annual?
Sure, like annual, yeah.
I feel like when I talk about the enrollment periods almost at the close of the appointment, when I'm talking about the expectations. We'll enroll, and if it's a med sup and a PDP, I'll summarize what we just like went over, and I'll say, now this med sup we're going to review on the back end every year, blah blah blah, on the anniversary period, and then just expect every fall we'll reach out and we'll review your drug plan as well.
I like that. Okay.
That's when I talk about enrollment windows.
I think, again, just setting the right expectations, knowing when to have that conversation so that people can understand, okay, this is when I should be expecting that.
Yeah.
I think expectations have everything to go with a successful client-agent relationship.
Agreed.
So the next thing, again, talking about this is going to be Medicare Supplement versus Medicare Advantage. And why is this so difficult? In my opinion, is because Medicare Advantage plans are being talked about more than they've ever been talked about, thanks to the Joe Namath ads, in a way that is just like incredibly misleading and incredibly wrong.
And just the terminology. There's too many like Medicare Supplement, Medicare Advantage, Medigap.
Never mind that. They also go by Medigap and Part C. Yeah.
There's too much just jargon, and people think that a Medicare Advantage is a supplement. So many times I'll ask somebody and they'll say I have a supplement, and they don't. They have an advantage. So I think that is also part of the confusing.
So how do you combat that? If somebody says like, oh, I have a Medicare supplement, here's my card for it, and it's an MA plan, do you correct them and say, actually, this is an Advantage plan, or do you just kind of go with it and be like, okay, well, this is what this includes?
I do correct them so that they understand that there's a difference. I do. Maybe that's not right, but no, I correct them.
I think I've worked with agents that say, like, I don't correct them. I just let them do what they want to do, and then I just kind of enroll them so that they feel more comfortable. They feel like I'm not being confrontational. But then whenever they hear this stuff about these Advantage plans and they're already on one, like, if they don't know what they have, then they don't know really how good they have it or other opportunities out there.
Because they're so different, that's why I think I correct them. And if I'm meeting with somebody who is 64 getting ready to enroll, or they're 94, I go over the two pathways and all the options regardless. So I think I'm correcting and then explaining the differences too.
Yeah, I think that's, again, really important, and with that education factor. So how many of your clients, I will say this, how many of your MedSup clients are upset that they expected to have gym memberships, they expected to have over-the-counter benefits, they expected to have all this stuff, but they don't have it because they're on a supplement plan? Do you have a lot of people that get really frustrated by that?
Some are frustrated, but I think if you're choosing the supplement route, you're choosing it because of the full comprehensive like health benefits and not having the out-of-pocket costs that to them that outweighs the extras.
But do you have anybody that's like, I was told that I could be getting a free gym membership, I could be getting free food, I could be getting free over-the-counter benefits, why am I not getting that? And they're on a supplement plan. How do you address that conversation where they may come at you being more frustrated just because they are just not aware of what that means?
Yeah. How do I combat that?
Yeah.
I mean, I sit there and educate. Well, you're not getting those because this is what you're getting. Those plans that have all of those things are something that function. It's a whole different route of how you can get your health care. If you want that route, let's review it, but just understand you're going to have copays now if you're going to have those things as well.
How many people, once they have that conversation with you, want to continue to switch to the MA side? Or vice versa, after they see that, after they re-educated as to why they're on that plan, how many of them want to leave at that point?
I would say 10% of my clients maybe leave. Very interesting. Pretty small.
So it is really important, again.
I might not be the typical agent.
Sure. No, but again, just basically off your experience. My thing is, yes. My thing is Carrie, not Kara. Who is Kara? No, I'm just kidding, Brian. That's one thing, again, I think it is really important. We talked about this a couple weeks ago, especially when it comes to Medicare Supplement versus Medicare Advantage plans. It's to not sell the plan, but to sell the why. You can enroll somebody and you can listen to somebody and they be a classic case of, oh, they need to go the MA route, or, oh, they really need to go the MedSup route, and you can enroll them in that. But if you're not really expressing why that is the case and your ability and like really selling the why behind it, then it is really easy to get confused as to why they're on that certain thing, and it's really easy to lose that business. So explaining not just MedSups versus Medicare Advantage, but the why behind why you have them on that plan, I think is a huge difference maker there.
Do you think most of your agents or the agents in the industry truly explain both sides? Or if someone comes in and just says, I want to sign up for Medicare Advantage, Do you think they just sign them up, show them what's best, or do they present
I think it's
both?
really split. I think that's a really great question. I think it is genuinely really split. I would love to say that a lot of agents are the same camp as you, of being like, if a person comes to me and they say, I want a MedSup Plan G, that's what my neighbor has, I want exactly what they have, I think a lot of agents will say, perfect, that's an easy sale. Here's an application, press hard 3 copies, you'll have your cards next week. I would love to see more agents talking and saying more of less of, this is what you say you want, but let me make sure you truly understand what your options are. And I'm still going to go through and give you the full spiel, but I want you to be really aware of what your options are and what you are actually buying into. I think, I'll say it like this. Call centers aren't going to do that.
Right.
The call centers are going to be, you're calling, you say you want this, perfect, I'll sign you up for there, never talk to you again. I think that's where agencies provide their value is on the aspect of education, which is why I love this page of the Medicare and You Handbook. This is the 2 pathways. I know Carrie's talked a lot. You've actually kind of made your own copy of the 2 pathways, but this is page 11 of the 2023 Medicare and You Handbook, and it is by far one of the best tools to teach somebody the major differences between a Medicare supplement and a Medicare Advantage plan.
Absolutely. I mean, I wouldn't function without that.
Yeah.
I mean, I have to have that.
And again, it's from the Medicare and You Handbook, and it is, so it is compliant. It is something that's created by CMS. It is a compliant piece. This is also a great way to bring up Medicare Advantage in an appointment in a compliant manner. Because to talk about Medicare Advantage and Part D in depth, you have to have a scope of appointment. And you can't say, do you want to talk about Medicare Advantage plan without it? Right. So this page right here is a really great way to say, no, you have 2 options with Medicare. You have the Medicare supplement route with the Part D, or you have this Medicare Advantage route. If you want to talk about the right-hand side of that, we can do that. I just need to collect a scope of appointment because those are government-sponsored plans. So it's a really easy way to kind of bring up the conversation in a compliant manner.
Absolutely. And you talk about, it being legit and compliant, even though I use my own sheet that looks similar, I still pull this up out of the Medicare and You Handbook, and I'll say, look, these are just to prove that,
yes,
I'm talking about the same things. I'm being transparent. I just have another user-friendly, I guess, better visual that I use, but it's translated from this so that they know I didn't just make up something.
For sure. Brett asked a great question. He says, I feel like people who are really interested in the Joe Namath extras are driven by their income. And yes, to an extent, but I'll also say, in my experience, a lot of the people who are higher affluent clients are always looking for ways to cut expenses. It's kind of like the most, the really high income people are constantly looking for ways to save a penny and cut costs as well. And so that's what I feel like we're kind of seeing a transition right now of where it used to be incredibly income-based Medicare supplement versus Medicare Advantage plans. We're starting to see more affluent clients go that MA route because of those extra bells and whistles. And honestly, a lot of the times because they're able to afford the co-pays and afford the max out-of-pockets, maybe compared to your low-income individuals. So I know, again, if you tell somebody, a lot of your more affluent clients are interested in finding freebies, and MA plans come with a lot of them.
Absolutely. And I agree, Brett, that they are driven by their income. But even if I have somebody, obviously you have to take finances into account when you're picking which route you're going to choose. If they are low income, the first question I always ask back to them is, do you have, are you a frequent user of your health care? Do you have pre-existing conditions? Because if you do, that still might not be the cheaper route for you.
For sure.
And so then that's where, we really fine-tune a cost analysis.
You know what? I think that's a really incredible mind shift that you just kind of put in me just now. We all saw it. It happened. But going from MAs versus MedSups, from income-based to utilization-based, because a low-income person who's relatively healthy may be better to go, or I should say this, a high-income person who is unhealthy or should go the MedSup route, if they're incredibly healthy and don't use their plan, the MA route might be a good option for them because then they do get all the free stuff and they're not utilizing the plan like another individual would. You said it way more better than I did.
Way more better?
Way more better. Way more better. You're more smarter than I am in most of these cases.
We do have a text that was distracting me, and I'm not exactly sure what it means. It's from good old Brian,
The
of course.
cinnamon roll. Oh, yeah. So Brian always talks about my cinnamon roll bun.
Oh, okay.
He really
Cinnamon
gets
roll.
a kick out of my little spiral
Yeah,
that I
that's
have
it.
going up here. So
I was thinking something in the background.
what am I doing? No, 'tis I. Okay, I kind of messed up my slides. So after talking about Medicare Supplement and Medicare Advantage Plan, the last thing that I wanted to talk about and explaining to your clients is going to be Medicare Supplements, Plan G versus Plan N. And the reason why I wanted to talk about it specifically is that you are going to see the insurance carriers really start driving the conversation behind Plan N. And a lot of agents are uncomfortable to talk about it, not because it's a really great option, but because they really just don't know how to explain Part N copays. They don't know how, or Plan N copays. And more importantly, they don't know how to explain excess charges. Because excess charges can sound pretty scary because it's an undisclosed amount.
Yeah.
I'd be really interested. Feel free to text the number, but how many agents here are familiar with Plan N? How many agents have sold Plan N? And I'd be really curious to know how do you discuss Plan N? Because you do have to talk about the copays and you do have to talk about those excess charges. I think excess charges is one of the most confusing topics when it comes to a Medicare Supplement Plan N. So that's why a lot of people avoid the topic altogether.
And I think it's what adds to the confusion is, excess charges, you can't estimate them. And you can't guarantee somebody that your doctor will or won't have those excess charges. Like, we don't know. And I think that's what makes Plan N, I guess, scary. One of the ways that I explain it is I'll say a Plan G and a Plan N are identical, except Plan N, you could have the potential of having more copays. I had 2 clients that came to me. One, she never paid a copay. The doctors that she went to, they decided to accept Medicare's assignment, which means they're not going to bill above the Medicare allowed amount. I had somebody else to where she had copays every time she saw the doctor because that doctor chose to balance bill the member excess charges or above what Medicare allowed.
And I think that's really, again, important to kind of talk about the numbers of that. I just put the numbers on there. But reminders, guys, there's less than 5% of providers don't accept that Medicare assignment. And so the most notable is going to be...
Less than 5%?
Yeah, less than 5%. The most notable is going to be the Mayo Clinic. That's kind of the major one that doesn't accept... Would that make sense for your client? Were they utilizing the Mayo Clinic?
No.
So theirs was a separate one?
Yes. It was actually my grandma.
Really?
Over in Kansas City. Yes.
Yeah. So
she was on Plan N and always had copays at the doctor.
So the way that the copays work for the doctor and for the emergency room is that every doctor, as long as they accept Medicare, not a Medicare assignment, but as long as they accept the Medicare, that doctor could have potentially up to a 20% copay with Part N and up to a 50% copay.
$20 copay.
Yeah, sorry.
Not
$20 copay if they go to the doctor's office, $50 copay if they go to the emergency room. Very rarely is it ever like that high, but it has the potential to, depending on why they're there and how that visit is being coded. So the way that I describe Plan N to an individual is I always go through, again, I always talk about Plan N, Plan F, and Plan G.
Yep.
Even though
those are the 3.
Exactly. Plan F, even if it's not available, I still mention it because the majority of your veteran people
are going to ask about it.
Because they've heard about it. So I always say, the higher the premium, the higher the coverage. That just makes sense. Plan F, it's going to be your highest premium, is also your highest level of coverage. And you're not available to have a Plan F, but you are going to hear about it. Just know you're not eligible for a Plan F because of when you aged in. Plan G, it's the middle of the road. It's going to have the middle amount of premium, higher than a Plan N, lower than a Plan F. You are going to be responsible. The only thing you're going to be responsible is going to be for that Part B deductible. We've talked about that. It's going to be around, $200 every year. It's going to be way cheaper than the Plan F. It is worth your money to just pay for it than it is to invest in premium you may not lose. Last but not least is Plan N. Plan N is going to have the lowest premium of the 3. Lowest premium, though, is going to mean you're accepting more risk. You may have more out-of-pocket expenses. Plan N has 3 moving parts to it. You have a copay, you have the deductible, and you have excess charges. You'll have up to a $50 copay on ER visits, up to $20 on doctor's visits. Most likely not going to be that much, but expect budget to pay that much if you're anticipating on using that benefit. Part B deductible, just like Plan G, expect to pay that every annually. Last but not least is excess charges. If you go to the Mayo Clinic, you're going to run into excess charges. If you want to...
Is that the only one?
It's not the only one.
I was going to say, it couldn't be.
Not the only one. It's less than 5% though.
Yeah.
So you ask, are you going to use the Mayo Clinic? This is where this is going to come about most often. Also, what we'll do is we'll go and look at your doctors that you do use on Medicare.gov and see if they accept assignment. You as the client, you don't need...
No clue. No clue you could do that.
This is what I do here. You as a client, you don't need to know what accepting assignment means. Let me know who you use as your doctor. I'll let you know if you're going to run into a problem with Medicare with having to pay excess charges.
Do you guys know that?
This is
I didn't
what
know
do
that you
here.
could do that on Medicare.gov.
So, yeah, Medicare.gov, you can go look at providers, see who accepts assignment, who does not.
So you can estimate.
Not for
If
the
you would
copays,
have it.
not for the
But you
$20
would be
copay
able
and the
to
$50 copay.
tell them.
If they're going to a doctor that does not accept assignment, then don't put them on a Plan N. Go ahead and put them on a Plan G.
Interesting.
But you can tell that ahead of time if you talk to them about their providers. So David is asking, why would excess charges come into play with the Mayo Clinic? That means Mayo doesn't accept original Medicare. Not the case. It actually comes something called excess charges. Excess charges happen whenever Medicare says, okay, here's how I explain excess charges. Your client, if they're asking specifically what they are, you can give them this explanation, but it's not as, again, like they don't really care. Check to see if their providers accept assignment. If they do, don't talk to them about excess charges. But here's how I just explain excess charges. As I say, you go to a doctor and they do accept Medicare, but they don't accept excess charges, or they don't accept Medicare assignment. What that means is that Medicare will say, you're getting your knee replaced, we're going to pay you $100 to replace this person's knee. That's how much we're going to say you can charge this person to replace their knee. The provider, aka a Mayo Clinic, can say, we're going to take your money, but I'm going to charge more than the $100 that you're going to allow me to charge. Now, most people don't do that, and that's because they get some pretty significant tax breaks for accepting assignment. So that's why most providers go ahead and accept it. Medicare will say, you know what, you can try to charge more than $100. We'll let you do that. However, we're only going to allow you to charge an extra 15% more. So instead of a person saying, okay, Medicare is going to pay for $100 of my knee replacement, they can only charge an extra 15% more. The excess charges are going to be that extra $15. The 15% more than what Medicare allows them to charge. And again, that only happens if the provider does not accept assignment. Less than 5% of providers out there do not accept assignment.
So they can accept Medicare. It's just if they decide to, I always say, balance bill.
Exactly.
The patient. So
that's exactly correct.
If crutches cost $115, Medicare is going to pay $100. They're going to send you a bill for $15.
Exactly. Yeah.
If they don't accept Medicare.
But again, they can only do up to 15% more. Now,
Right.
$100 for a knee replacement is not a lot of money. You're talking about several dozens of thousands of dollars there. So again, we're not talking about an extra $15. The excess charge can be a significant amount, but that's why I always say just double check with their providers and see if they accept assignment.
And the only risk is you can't estimate it. You know,
there isn't.
Me, like, if somebody is debating between a Plan G and a Plan N, when I talk about, what's the risk between the two? Plan G, we know your out-of-pocket cost is $233. You're going to pay a little bit more per month. Plan N, you're going to pay less. You most likely will just have that $233 deductible, but I can't estimate for you beyond that.
And again, it's all about...
It's likely that you won't have more, but I just can't even estimate it.
But that's why I like to say that the higher the premium, the lower the risk.
That.
And that's what I always say. That's F is the highest premium, the lowest risk. N is the lowest premium, but the highest risk. So just setting the right expectations of knowing, like, this is something that potentially could happen. And let's see. Somebody was asking if there was a way to see had to miss the beginning part of today's presentation. These are recorded and they will be posted immediately following. So just make sure you check and subscribe and like our YouTube page. You'll have access to all of our previous recordings from Medicare Cafe. So guys, that is what we have today to talk about confusing conversations and how to explain confusing topics to your clients and to beneficiaries. The important thing here is just to kind of realize that, like, yes, you just keeping it as simple as possible.
Yeah.
Again, like, I liked your description of Medicare Part D, not even going to specific numbers, but just saying, like, expect a change around this month.
Right.
Expect, this is
Around
what we're going
this.
to estimate, but it will look different month to month. Having those conversations. Again, I think it just comes down to keeping everything as simple as possible.
Yeah, and reading your clients. Like, I have a client who is an accountant and an attorney, and I mean, I know I have to be on my game, and like, he wants every little number. Most of your clients, they're not going to want that little detail.
Doctors, lawyers, and teachers.
Yep.
Doctors,
Yep.
lawyers, and teachers,
So
they
just
want every
read the room.
detail. Yes. And the majority of them, like me out there, will never look and never check. They just
Right.
want comfort knowing that somebody's watching this stuff for them.
And I always tell them, if your prescriptions change, if the cost change significantly, that's why you have me. Call me if you.
Because again, like, I know you said that you go through and actually, like, will do a check on all of your clients to see, like, who needs to change, who doesn't on a monthly basis. But I honestly think, like, do that because it's working for you, obviously. But I think it's equally as important just to say, if, set the expectation of, I am your first call. If
Right.
you see an advertising that piques your interest, I am your first call. If a claim doesn't get filed correctly, I'm your first call. If you're not happy with your premiums, I am your first call. And really training your clients to have a conversation with you versus trying to do anything on their own.
Oh, sorry. I have to create a channel.
So having a question, trying to chat, says I have to create a channel, wanted to ask
On YouTube, is that what you mean?
percent on who accepts assignment. So yeah, again, I am not a YouTube guru. So if you're trying to chat on YouTube, you have to have like an account set up. So making sure that you're logged in with if you have like a Google, like a Gmail account, you can log in with your Gmail account and have the ability to chat and have conversations with that. But that's why we also set up the texting line, is to make sure that you can reach us and ask us questions as we're going. The percentage of providers that do not accept assignment is less than 5%. Less than 5% of providers out there do not accept assignment. So.
And the big one is Mayo.
Mayo Clinic is the big one.
I'd be happy to help them.
Oh, that's Ben. Ben from our office says if you have questions on how to work YouTube, call our office and ask for Ben. He is here and is more than happy to get you set up with our YouTube content.
Great content as usual. Sorry I missed the last two.
Yeah, and
glad to have you back.
Yeah, glad to have you back. And again, guys, this content is recorded and posted on our YouTube page. So feel free to go and pick and choose what you want to listen to. But that's why we wanted to move it to the YouTube, so that we're able to listen to it on your time. Love when we can get you guys live, but understand that the insurance waits for nobody. So we got to make sure we can be flexible with your time, just like you guys have to be. Oh, hi, Chris.
Yeah, that's what I just texted. If you guys text us, again, there's no, your names don't pop up. So if it's the first time you're texting us, text us your name also so we can add you to the system.
Yeah, so we know exactly who it is. Unless you want to remain anonymous, then you can,
fine.
text us a picture of the middle finger, I guess. I'm fragile, don't do that. Awesome, guys. Well, any other questions, comments, concerns, threats, and our promise?
Oh, what don't accept Medicare?
Oh, I don't know the percentage of people who don't accept Medicare.
I think it's like less than 1%.
I don't know. I've not done that research, but that'd be interesting to find out.
I thought it was less than 1%. And it's mostly the, like, holistic doctors,
people that, like, Medicare won't pay for.
Right, or some, like, chiropractors,
more
but
specialists, PCP based. Interesting. Yep. Well, that's a good question. No, I don't know. I know a lot more don't accept Medicaid than Medicare because Medicaid is state ran. Right. And there's a lot more, again, since it's not a federal program, a lot more confusion. But again, assignment
is different than Medicare.
Accepting assignment is not the same thing as accepting Medicare. And that is something that a lot of people don't understand. And one of the biggest misconceptions about that, it's all a tax thing, honestly, when it comes down to it, of why you accept Medicare but you don't accept assignment.
Accepting Medicare means you bill Medicare. Mm-hmm. Accepting Medicare assignment means you accept what Medicare pays.
Chef's keys. Awesome, guys. Appreciate you all hanging out with us today. Join us next Tuesday, same time, same place, to talk about cool and fun antics that we have going on. Any final last words of wisdom?
Don't think so. Have a great Tuesday.
Awesome. So until next time, guys, have fun.
Make money
And give impeccable service. Thanks, guys.